Hi, this is Clyde Yancy, Chief of Cardiology, and I am delighted to congratulate you on having one of the most highly recognized cited papers in the Department of Medicine this year. Congratulations.
Thank you very much.
Graham is a senior fellow in EP, joining our faculty. Your work done with Rob Passman is of such considerable importance. So give us a description of the work you did and why it's important.
You know, we have thousands of patients, just like every other major academic institution, that have these devices implanted for anti-tachycardia therapies or bradycardia therapies, but they also have the benefit of detecting abnormal heart rhythms that exist.
So for everyone listening, what we're really talking about is implantable defibrillators, cardiac resynchronization devices, conventional pacemakers. These devices are not static. They're like implanted telemetry devices, correct?
That's exactly right. So we're able to see kind of the evolution of their rhythm and, frankly, detect things that we otherwise wouldn't be able to detect.
Tell me the first finding of significance.
Absolutely. So we were able to look at or link two very large databases and create a composite database of 20,000 patients. And we were able to see that device-detected atrial fibrillation in and of itself is associated with an increased hazard for mortality. But importantly, we're able to quantify device-detected atrial fibrillation and split it into patients who have different degrees of atrial fibrillation burden. And what we found is that patients with persistent or permanent device-detected atrial fibrillation actually also have a higher hazard for mortality than those with paroxysmal or lower burdens of atrial fibrillation.
So this is incredibly important because we no longer talk about atrial fibrillation as a binary event. Either yes or no, you've had it or you have it or not. It actually has a dose response, if you will.
Precisely. And importantly, I'm actually going to segue to our second finding in
Please.
Another paper in saying that atrial fibrillation burden isn't static over time. In another analysis, looked at changes in atrial fibrillation burden or changes in the maximum daily duration of atrial fibrillation and found that patients who have 1 hour to 23.5 hours of a maximum daily atrial fibrillation at baseline and then had a decrease in their atrial fibrillation burden in follow-up actually had lower rates of stroke and mortality.
And you also did some additional work about healthcare engagement activities where hospitalization, et cetera. What did you find?
We found, again, that patients with persistent or permanent atrial fibrillation had higher rates of healthcare utilization, higher healthcare costs, greater heart failure hospitalizations than those with no AFib or paroxysmal AFib, again, showing that dose-response relationship between atrial fibrillation burden and important clinical outcomes. I think the biggest take-home is that atrial fibrillation is not binary. That different burdens portend different consequences down the way, and that being able to target therapies to specific degrees of atrial fibrillation burden may really impact our patients in a positive way.
So once again, congratulations on being cited as a highly relevant, very important paper. Congratulations on joining the faculty.
Thank you.
Continuing this work.
Thank you.
Congrats to Rob Passman for being a spectacular mentor.
And I'd be remiss if I didn't thank you and the entire division for the expert mentorship that I've been the beneficiary of for the past 8 years.
We'll reconcile all this on the golf course.
Now we're talking.